Good evening, good morning, everyone. My name is Steve Kurtz. I'm moderating a series of webinars all related to metal sensitivity in total joint replacements. In our first episode, I'd like to welcome my colleagues, Marco, Jeremy, and Bill, and I'd like to invite them each to give a quick, say, 120-second update on their backgrounds before we get into the thick of things. Marco, do you want to go first?
Sure, absolutely. Thank you for having me. It's an honor and a pleasure to be here with all of you guys today. My name is Mihalko Caicedo. I've been in the field of immune responses to biomaterials for, goodness, the last almost 20 years now. Most of my professional career has been spent at Rush University Medical Center in Chicago in the capacity of student, technician, postdoctoral fellow, and now adjunct professor in the department. I also run a diagnostics company called Orthopedic Analysis, which concentrates in looking at metal sensitivity responses in people that may be concerned about reactivity to their orthopedic implants, either pre-op or post-op. And it's been a long ride. It's been a very interesting ride in the last 15 years where I feel that the topic has gained a lot of interest, and a lot of people are starting to understand what the risk factor of a metal sensitivity is to their orthopedic device.
Thanks. Dr. Mihalko?
So I'm Bill Mihalko. I'm a arthroplasty-trained surgeon scientist here at the Campbell Clinic and the University of Tennessee Health Science Center. I also chair the biomedical engineering graduate program here. And I've done a lot of work, not just clinically as far as taking care of patients with metal hypersensitivity, but we've also done work in the lab. I've collaborated with Steve and Jeremy in the past here, as well as Nadim Halab up at Rush. And I've looked at in vitro studies looking at how macrophages react on cobalt chrome. And we're also doing retrieval analysis studies and histological studies to take a look at how revision synovial tissue reacts and what content of metal and other byproducts are in the tissues. So I've lived this and researched this for the past couple of decades.
Jeremy.
Yeah, hi, I'm Jeremy Gilbert. I'm a professor of bioengineering at Clemson University, and I direct the Clemson Medical University of South Carolina bioengineering program in Charleston. I've been in the faculty ranks since 1988, wrote some of the earliest papers on corrosion of orthopedic implants in the early 90s, and have been studying metallic biomaterials, medical devices, doing retrieval analysis, fundamental studies of tribal corrosion and corrosion, interactions of cells with electrochemically active surfaces, and basically have been investigating the whole realm of how metals and the human body interact.
Thanks. So I wanted to start with the basic stuff that's super contentious and confusing in the literature, which is terminology. Like hypersensitivity, metal sensitivity, ALTR, ARMD, Jeremy's favorite word, metallosis, trunionosis. Can we go through that a little bit to start off?
Sure, let me start.
Sure,
I'm going to add to that. There are things like metal debris or metal wear or things like that that don't actually truly describe the degradation products associated with the tribal corrosion mechanisms that happen on virtually every surface that wears in orthopedic implants. So we talk about metals and metal particles and metal nanoparticles, but almost universally, these are particles that have been reacted in the body through some electrochemical process. You can't have a metal these metals in the body unless they have undergone some sort of oxidation process, at least on their surfaces. And if the particles are small enough, they all react to become essentially oxides, phosphates, and other things. So we get lazy in our language with saying things like we've got metal debris in our body or metal wear in our body. It's got to be more precise language. So I appreciate you bringing that up, Steve.
Yeah, if I may just add in terms of, go ahead, Dr. Mihalko.
No, I was going to say, just as far as patients are concerned, they're more concerned about that metal hypersensitivity and the allergy aspect of it, and so that's much different than what we talk about as scientists and as surgeons, as far as what we see in the operating room or histologically. And there are a lot of metal reactions like Dr. Gilbert just talked about that are actually sometimes driven by macrophages, not necessarily lymphocytes, that are not necessarily hypersensitivity in and of itself. So we have a lot of different reactions that kind of get lumped together. So I agree with that. That there are some confusion within the literature about how we describe things.
So, Marco, this is setting you up. So, what? So we're going to set
aside
all that out.
Plan.
What's metal sensitivity versus metal hypersensitivity?
Right. So those are interchangeable, right? Metal sensitivity is metal hypersensitivity. I think the biggest misconception is when it comes to allergy. People call it metal allergy, or people want to define a hypersensitivity as an allergy. In the world of immunology, basically, an allergy is an exaggerated immune response to something that is not supposed to be harmful, right? So we can talk about immediate type hypersensitivities, which in immunology is defined as an allergy. We're talking about a peanut allergy, hay fever, which is mediated by antibodies like IgE and then mast cell degranulation, histamine, where you get those type of immediate responses with hives, and in the worst cases, anaphylaxis, right? Now, when it comes to a metal hypersensitivity, even though some people want to describe it as an allergy, it's technically not an allergy. It's a hypersensitivity. It is mediated by T cells. It is delayed, so it takes a few days to develop. And it really has nothing to do with an antibody response. So I think we're in a place where most lay people would just define a metal allergy as something bad that happens with their implant. But unfortunately, that terminology is just not correct. It's not a typical allergy that is mediated by antibodies. It is a delayed type hypersensitivity, which is mediated by T cells. To make matters more complicated, there are other types of hypersensitivities. There's hypersensitivity type 2 that you get in hemolytic anemia, hypersensitivity type 3, which is also mediated by antibody-antigen complexes like in lupus. So, the terminology becomes really messy really quick, but the definition of a metal sensitivity, it is really a delayed type hypersensitivity that is mediated by lymphocytes. Now, going back to what Dr. Mihalko mentioned, not everybody that responds to metal debris has a hypersensitivity to metals. There is an innate component to that, and there's an adaptive component to that. Most of us will respond to orthopedic metal debris, corrosion, and wear with our innate immune system, macrophage reactivity. A certain group of people may respond with the adaptive immune system in addition to the innate immune system and develop a hypersensitivity, which can also be in a spectrum of having subclinical hypersensitivity or extreme hypersensitivity leading to major clinical symptoms. So there's a lot of terminology, but a metal allergy is really a metal hypersensitivity mediated by T cells.
Bill, do you care whether the patient is hypersensitive to metal when are you worried about the future of the implant or about the patient being really concerned, and so you should do something about it because the patient is concerned, not because it's a real clinical issue?
So you're talking about when a patient comes to an appointment, we're talking about surgery, and they say, hey, I am allergic to nickel. That's the most common one. Is that what you're talking about? What do we do from there?
Yeah.
Yeah. So, uh, you know, the first thing is number one, if they're bringing it up, then you need to be concerned as well. Okay. And so typically for those patients, I do not trust patch testing. And, that's probably another debate as far as, what are the mechanisms of reacting to a patch test versus reacting to a deep tissue reaction, because they're different mechanisms. Your skin patch testing is moderated by Langerhans cells, which are not in deep tissue. And so I typically will do a lymphocyte transformation test. And if they come up moderate or higher reactivity, then I will talk to them about using an alternative type of metal implant, whether that's a coated or ceramic, depending on whether we're talking about a hip or a knee. So if they're concerned about it, I definitely address it with them.
I guess then my next question is like, how many patients, despite how many patients are concerned about it, how many people actually are metal hypersensitivity, have metal hypersensitivity when they're walking into a clinic versus when they're presenting for a revision?
Right. And I will tell you, as far as lymphocyte transformation tests go, that I would say probably 1 out of 8 come back with something that has tested moderately reactive. And that doesn't always have to be a metal, that can be benzoyl peroxide, other byproduct as well.
Marco?
Yeah, I agree. I think going back to patch testing very quickly, Dr. Mihalko is correct. So, and I'll give a shout out to a famous immunologist, Dr. Matzinger, who basically really emphasized the fact that immunology reactions matter in terms of location. Location. Your immune response on your skin compared to your gut or your blood or your eye will be vastly different, even if they see the same antigen. It is just the ways our body work. We want to minimize collateral damage from an inflammatory response. Now, not only do skin tissues have different antigen-presenting cells like Langerhans cells, but they also have a high proportion of T regulatory cells. By the way, the group that basically worked on Tregs for the last 20, 30 years has just won the Nobel Prize in Physiology, describing how T regulatory cells work. And skin has a good 20% of CD4 positive T cells as T regulatory cells, which dampen inflammation and regulate the immune response. Now, in blood, we only have 5 to 10% of them, which is what you would see in deep tissue. So again, depending on the type of test that you do, you need to pick the appropriate scenario for what you're looking for. So if we're looking for a metal sensitivity around the joint, then a blood test is likely going to be a better proxy than doing a skin test. Now, in terms of the amount of people that are metal sensitive, obviously, we work with all these patients, and we do see a lot of patients that are not only sensitive to nickel, but also to cobalt and chromium, and sometimes even titanium alloy particles. And what I think is still something that is not well understood is that it's not a binary issue. People cannot just be sensitive or not sensitive. We have a huge spectrum of metal sensitivity where any specific individual may respond to the lowest concentration of nickel or cobalt tested, and that person is severely sensitive compared to somebody that responds only to the high concentration tested at a moderate level. We still cannot determine which one of those will respond in vivo faster or more potently. But that's what we're working on, to make a distinction as to how sensitive a patient is, because it really, really matters. Somebody that has a mild sensitivity at the high concentration may not have any clinical issues whatsoever, yet that patient is going to be described as metal sensitive. Now, a patient that has 3 concentrations at the highly reactive range is far more likely to respond to any of those materials compared to somebody that does not have the level of reactivity. So that's the distinction that we're working to make and understand better, so that physicians can actually make a better informed decision as to what to use and what not to use.
So is this a rare problem, or a common problem, because I see that in terms of patients walking into the clinic that have metal sensitivity. I know you mentioned there's 1 in 8, Bill. I've seen in some of Nadim Halab's like early publications 25 years ago, he thought that maybe there were 25% of patients having some form of metal sensitivity. There's like some recent work by Robert Langdon suggesting that maybe 1 in 10 patients may have some susceptibility from in their genetics to metal sensitivity. Like, what percentage of the patient population, at least in the U.S., do we think is this an issue? And everyone can talk about everyone. I'll let everybody answer that, starting with Bill. You can stand by 1 in 8, or what do you think is?
Yeah. So once again, it depends on what definition we're using. Because everybody who has a positive skin patch test doesn't mean they're going to have a problem with their implant. And we have studies out there. Mayo's published, a series, looking at, well, just because you have a positive patch test doesn't mean you're going to have problems with your knee replacement. And, so it depends on what we're talking about here, because really we don't know the numerator or denominator, because we don't patch test everybody before surgery. The dermatologists would all like us to, but, it's not indicated really. And Josh Jacobs, Stuart Goodman and I wrote a AOS Now article about that about 12 years ago. And, so I would tell you, we don't know the numerator denominator right now. So it would be very difficult to tell. We just know that, 15% of patients are not satisfied with their total knee replacement, and what portion of those are metal sensitivity, we don't know. It's probably a small percentage. And if you look at the ACUS website, they actually say that it's rare that anybody would have a failed loosening or a failed joint replacement from a hypersensitivity issue.
Marco, how often is it? What are your thoughts?
So the going back to Dr. Halab and Dr. Jacobs' paper from a few years back. So based on both patch testing and LTT testing, it is believed that 10 to 15% of the general population is allergic to metals, and I agree with that number. I think if we get 1,000 people right now off the street and we test them, a good 10% to 15% females having a higher rate compared to males, by the way, they will come back positive for either nickel, cobalt, or chromium. Now, in the same study they performed, they looked at people with well-performing implants. People were not complaining about their joints, but they tested them for metal sensitivity, and 20 to 25% of them came back metal sensitive, meaning that there's some level of sensitization, but not enough to induce clinical symptoms, at least at that time point, right? And then in a group of patients that had poorly performing implants, not due to infection or mechanical issues, about 55 to 60% came back sensitive to metals, which kind of gives you an indication that, again, not everybody that has a metal sensitivity goes on to develop a failed implant, but the risk factor is definitely there. And what we are working really hard to try to figure out is how do we hone in on that risk factor in terms of the level of sensitivity that would give you a highest risk factor for implant failure. I wouldn't call it rare. I think obviously the vast majority of implants do fantastic, but the percentage of people that do develop a hypersensitivity, I would go as far as to say that it is not rare. It's getting up there with the millions of implants that we put every year. That number is growing, and I think if the patient has a history of not being able to tolerate metals on their skin, jewelry, for example, it's a pretty good indication that their reactivity in deep tissue is going to be there. And those are the patients that I think, physicians need to be more concerned about.
Jeremy, your thoughts on this whole incident thing?
I have a quick follow-up. Can I do a follow-up on that?
Oh, sure, go for it.
Yeah, because I think there's an issue here with, I agree with everything, that's been stated, but the question is, okay, why are those 55 to 60% of patients who have a poorly functioning implant, why do they
Well,
become positive and why are they testing positive? Because, uh, you know, when I take a look at somebody who's not happy and I go through my algorithm, starting with, okay, they're not infected, going right down the line, okay, I can tell you that many times we find a reason why they wouldn't be, happy with that implant. So the question is it because of suboptimal alignment, or is it because they're metal sensitive? And so I think that's why we don't know the numerator and denominator at this point.
Bill, I hate to deflect, but that is an entirely different topic than, and I think a
Gotcha.
great topic for a second webinar or a second episode is to talk about metal sensitivity and revision. Here we're just trying to say is like people walking in the door to arthroplasty, are they like, what is the role of metal sensitivity at that point? Jeremy, do you have any, shall we say, last thoughts on this before we adjourn our talk on metal sensitivity and I guess primary total joint replacement?
Sure. Well, I will completely and totally defer to my two colleagues here as to the fractions and percentages in the clinical population. I'll just point out that metals don't behave the same way in different people. So we talk about that the implant causes problems to the patient, but there's an interaction there that I think is important. The extent of degradation of the metal surfaces, the mechanisms by which they occur, the volume released, all will play some role there. There's other reactions that perhaps we don't even know about that may be facilitating some activation towards an immune reaction, again, that we don't know about. Electrochemistry, corrosion is a two-way street. You need oxidation and you need reduction. You need an environment and you need an alloy. And so that environment, we call it the patient, is highly variable and can affect the processes that go on to all of these implants in dramatic and significant ways. And so I'm not surprised to hear that the fraction of people who are sensitive goes up as you have more damaged or degraded devices. But again, we don't know much of that story of how the body affects the implant to lead to more debris or other reactions that we don't even know about. So there's a lot that is yet to be known, at least from the biomaterial side.
And one last question for Dr. Caicedo. So the other issue here is how other factors play a role in who becomes hypersensitive to metals. Okay, and so what about geographic location, as well as it's been shown that certain professions are going to be exposed to certain byproducts of metals, etc. And so that plays an important role in who's going to become sensitive, yes or no?
Absolutely, yeah. So prior exposure is huge. I mean, if we're talking about patients preoperatively, the only thing that we can go by is have they been pre-sensitized or not, right? So you're absolutely right. We have metal workers, painters, any profession where you have been exposed to metals, those individuals tend to already be pre-sensitized, and we actually do find them through testing. Those are the ones that are at the higher risk. Now, having said that, there is going to be a percentage of patients who have never really been exposed to enough metal to see if they can become sensitized or not. And it is unfortunate that the only way we're going to find that out is after a metal implant goes in. And like Dr. Gilbert was describing, if there's enough corrosion and depending on the mechanism in the patient's physiology, that will induce a sensitization, at which point there's really nothing we could have done to prevent it because they were not pre-sensitized. So the ones that we can find are the ones that have been exposed to metals in the past. Now, Having said that, we deal with a lot of stuff on a daily basis that contains metal, especially now phones and laptops and everything that can have nickel or cobalt or chromium in it. We can easily become sensitized, but there is a good number of people that are not sensitized yet, but do have the ability to become sensitized, and they will likely become sensitized if there's enough exposure, enough metal challenge antigen once the implant goes in.
And that's a very, that is the one concerning issue, is that we can't predict that. And,
Exactly.
Yeah. And
And,
so
and that's
that's
when,
another reason.
so I was going to say, and that's when, already, I mean, we do work with a lot of physicians that basically if there's any indication whatsoever that the patient may be reactive or that the patient could react, they immediately go to a hypoallergenic component to try to avoid all of that from the beginning. So, I mean, that would be one issue or one way to try to counteract that risk factor. But we're not there yet where every surgeon is going to use a hypoallergenic component. But I mean, in hips, you're already seeing that. There's a lot of ceramic heads used in hips to avoid that issue, because they're not pre-screening patients to see if they're metal sensitive or not to use a ceramic head. They're already using it to prevent any cobalt chrome issue in those specific patients. We're not there yet with knees, though.
All right. Well, I think we've talked a lot about primary surgery and all these factors leading into the complicated topic of metal hypersensitivity. And if you thought it was clear, wait until our next webinar when we talk about what happens after the implant's in you and the odds or the risks of how metal hypersensitivity may change after the implant's put in the body and its role potentially in revision. So thank you very much, and good night or good afternoon to the rest of you. Bye-bye.
Goodbye.
Thanks, everyone.